It's a home run.
All right, so thank you to everyone. Welcome to the first in a webinar world series for On the Mend, which we have titled Is Digital Physical Therapy a Home Run? And we're trying to understand the opportunities and the limitations, the challenges that come with introducing technology into an industry that is known for its resistance to new ideas and technologies, obviously because people are involved and they are complex beings, and we want to understand their needs and try to address those. So I am Wesley Fogel. I'm the co-founder and CEO of On the Mend. We have built a digital platform providing holistic, tailored support to patients and connecting them to healthcare professionals who can provide more responsive and data-driven care to patients. And we've been working with a number of players across the industry and over the years, and some of them are present here today. And we're very keen to have a hopefully very productive exchange of ideas and discussion and debate around the future of digital physiotherapy. And I'm very pleased to introduce our speakers who I'll be moderating for this panel. Nicholas May, the lead physiotherapy advisor for On the Mend, a leading physio specialising in trauma and orthopaedics, and expertise in clinical education and rehabilitation pathways. We've got Andy Henderson, the major trauma rehabilitation coordinator and senior physiotherapist with the Oxford University Hospitals NHS Foundation Trust, with experience in trauma, rehab and patient recovery pathways. And we have Mark Wilkinson, the director and lead physiotherapist for post-op home physio, founder of London's post-operative home physio specialists, providing bespoke at-home physiotherapy across all 33 London boroughs. So thank you all for making it here today. Really a minor miracle we all managed in everyone's schedules to come together at this time. So thanks so much. And I do want to sort of step away as much as I can, but I'll try and guide this conversation. I have some areas of sort of ideas to touch on in terms of the role of digital in physiotherapy, issues around compliance and engagement, evolution of treatment approaches, perhaps as well, collaboration between patients when there are new interventions being designed for them, as well as the resistance to change, probably the biggest one we might leave till the end. So I guess my opening salvo to maybe I'll start with Nick, if you want to go ahead, Nick. My kind of question to you really is, how you believe that digital health has changed the way that physiotherapists engage with patients. Go ahead.
Thank you, Wesley, and good morning to everybody online. Good morning to Mark and Andrew as well. Thanks ever so much for joining everyone today. Well, I think it's important at any discussion around kind of, well, where are we now is always, I think it's helpful to see where have we come from. And I think historically, just to sort of maybe exaggerate things a little bit to paint the picture, physiotherapy, as certainly in outpatient terms, has been characterised perhaps by long queues at the booking in desk and rushing to fill in outcome measures in the waiting area, certainly in the MSK world, and then an uncertainty as to when your next appointment might be. We'll send you the next appointment in the post kind of thing. And so you're very much seeking to try and maximise a very short window of time. You maybe get 30 minutes if you're lucky as a follow-up appointment. I think that's very much an NHS kind of scenario that would be consistent across many hospitals. Naturally, in private clinics and in private offerings, perhaps you get a bit longer, and perhaps you're not faced with the same level of demand. Historically, you might be facing some of those similar challenges, and then invariably in between appointments, you're taking away stickmen drawings, rushed, quick exercises that you got to get on with and get through them, and you end up with paper after paper of exercises, and you're not sure which is your current ones. And invariably, the recovery process is largely compliant on a sense of obedience towards trusting the process rather than an enthusiasm and feeling motivated to that. Then, of course, we had the bombshell out of the sky around the COVID era, and that through enforced rather than through choice of evolution, put the physiotherapy world in a place where it had to very, very quickly adapt to new ways of working, deliver things online, deliver things remotely, taking away the fundamental basics of close interaction with patients, reassuring elements of it. A lot of these things that are not conveyed through words, but conveyed through actions and conveyed through proximity to somebody. I think those were suddenly taken away, and the profession was faced very quickly with trying to evolve through a needs must. Since the COVID era, then there's been a sense of, well, where are we now? And I think where are we now is almost a picture of, to take a quote from a book called *Sapiens*, written by a psychologist called Harari, that we're in a place where we have all this technology and we don't know quite what to do with it just at the moment. And I think the profession is still very much finding its way in terms of how we use the different digital elements available to us. Historically, that we had stickman drawings on pieces of paper, and then of course we had software that came in to help us digitize a little bit of that. So there's been a slow drip that's been coming into the profession at times. But now, of course, when we talk about digital health, we're talking about telehealth, we're talking about wearables, we're talking about robotic therapies, we're talking about I suppose in many ways social media and how knowledge is shared across those areas. And of course, we're talking about artificial intelligence. So at the moment, there are a lot of different options available for clinicians. And the objective always remains the same, of trying to improve outcomes, be cost efficient, increase service accessibility, and enhance the patient experience, but also still maintaining the ethics of data security and patient confidentiality. So I think the challenges then for physiotherapists now are, how do you incorporate all of these? How do you take all of these tools that are available to you and use them in a way which enhances? As we love data, I think it's easy to get saturated in data. And so it's a question of, how do we work out what data is meaningful? Which tools help us to use that? But most importantly, the end result needs to be something which is still in the patient's best interest, and actually provides a tailored program for patients that doesn't produce a one-size-fits-all program for them. Now they have more variables, and I suppose the question to Andrew and Mark that I would pass on, having probably talked too much already, with apologies, is what are our decision points around this? How do we work out what meets that criteria of being relevant and useful for our work?
Andrew, I might.
Yeah, I think it depends on the particular client, doesn't it? You might use it for a certain client if they're open to the use of technology and apps and things, but it might be completely inappropriate for another client. So I think the first one's obviously consent, making sure that we're not pushing it onto people, to make sure they're engaged as well. That would be my main thing, is consent and motivation from the client.
Andy, how does that resonate in trauma?
I think from a trauma point of view, and specifically, the area that I'm working in, major trauma, I think the unique complexity of major trauma is a lot of it in terms of different specialties involved, and a lot of complexity of injury recovery. And I think the key thing with major trauma patients is it's not clean, it's not straightforward in a way. So I think what we've tended to find in major trauma rehab is that a lot of it's access to local provision as well, because with us being a major trauma centre here in Oxford, we get a lot of regional trauma that often, once discharged, will then go on to more local provisions. And what we tend to find when we get people coming back to our polytrauma clinic follow-up, that access to rehab is very, very variable. And I think it's trying to find out how we as a major trauma centre can better support the patients regardless of where they are upon their discharge, so that essentially we're enhancing their outpatient experience by improving their sort of discharge to next point of contact through outpatient physio. So I think what we're trying to really do is pull in all the areas of specialties that we have here, but then also looking at how we can improve the outpatient pathway, because we understand that a lot of problems that come through outpatients comes and stems from discharge. I think that's where we're major at. And what you're sort of saying there, Mark, in terms of consent, as sort of particularly major trauma, the age of pathology with major trauma is increasing. the average age now is significantly higher than it was. Yes, we will still get the population of significant body trauma through RTCs, through workplace injuries, but the mainstay of our major trauma is what was used to be called silver trauma, which is now platinum trauma, so to speak, and that is in more frail and elderly, and they may not have access to digital physiotherapy platforms, and I think it's trying to engage with that population as well, with the benefits of utilizing technology, and it may well come through a little bit of inexperience or through a little bit of naivety in terms of, can this work for me? But I think that's where we try and engage with family, with friends, with our outpatient colleagues as well. So I think that's where we're trying to go at it with from a major trauma point of view. But I think my first point was probably my most salient point in terms of the complexity involved with major trauma, particularly, is a real key challenge that we want to try and overcome with regards to rehab.
Andy, as a major trauma centre, you're presumably serving quite a wide geographical area. Would that be right? And with some of the complexities of the injuries, do you think that actually, in some respects, it actually physically attending follow-ups, particularly if you're living out in the more remote areas, that can present quite a challenge, one would imagine?
Absolutely, yeah. I think that's a really good point to make, because we have patients from essentially anywhere and everywhere. We have people from abroad, we have people from all over the region of the UK, because if they're visiting our sort of catchment area, we're based within the Thames Valley Major Trauma Network. We can have patients that, as you say, from the Highlands up in Scotland to very affluent areas in London, and the accessibility to health resources is really, really variable. So I think what we try and do is normalize as much as possible in terms of the aftercare. But we have a lot of challenges in terms of reaching out to areas where we've referred patients onto, and we try our best to sort of keep in touch with these patients as much as possible. But a lot of them get lost to follow up through they're being seen in additional clinics, or they can't access or come back to Oxford. So I think the locality is a real issue that we have, and that's not just within major trauma. We have patients come from whether it's plastics or through ophthalmology. We have a lot of, because of the nature of where we work, it's not a unique thing just for trauma, but it is a bit more unique for a major trauma centre. So I think we maybe need to engage with our colleagues in paediatrics and how well they do follow-up processes, things like that. So I think that's a real key sort of element to what we're trying to achieve in terms of accessibility to everyone who comes to the major trauma centre, regardless of where they're from. And we have a lot of visiting patients from abroad, and again, they sort of get lost in the ether when they leave us. And I've had patients from Romania, I've had patients from Africa, and we try our best to liaise with their equivalent of a GP or their equivalent of a TU, for example. But a lot of the infrastructure just isn't there. So we want to try and make that as as I said, as consistent as possible for as many patients as possible.
And I think that's a really great role for digital technologies. It is in many respects, to some extent, what you're describing there is patient traveling through a number of different silos. They're in one healthcare region, then they're in another healthcare region, and or maybe one part of the multidisciplinary team, then another part of the multidisciplinary team. And I think as long as I've been a practitioner, the challenge has always been continuity of care and joined up care. How do you maintain momentum that would start within an inpatient environment and not lose some of that? And obviously, people like Mark are doing wonders in helping to not lose that momentum with the services that they're providing. But I think one of the great roles for digital technologies within this is where the patient becomes the hub, and they get to add clinicians, and they get to the data that they're collecting through an app or through something similar. That follows them, and then they adding on the clinicians and taking them off as they move through different parts of the journey. And so I think the adaptability of technology, and in many ways the simplicity, having a a piece of technology that is almost a wagon wheel, and then you add on and take off the bits over the top of that, depending on where you are in the process.
Mark, anything from the home perspective on that?
I think what Nick was saying there about adding clinicians, I think that's important as well, because the client gets a feeling that the whole team is involved. We found that clients feel really supportive. They know that we're talking to, say, the nurse practitioner or the surgeon. They feel a lot more confident, and it could be something simple like we've fed back to via an app that the surgeon knows the range of movement, or we've said, okay, their knee flexion is 110 degrees, and they go and see the surgeon, and they have that information. The client feels a lot more confident about their ongoing rehab.
Interesting. Well, I think that's been really interesting. Look at the role of digital. I wonder, all these technologies would not really make any difference if patients aren't using them and compliant and engaging. I guess the question to you, Nick, to kick this off in terms of how we can try and boost compliance using the digital tools, especially things like mitigating dropout rates as well. What's your thinking on that, Nick?
Well, I think there's a number of different elements to that, because it almost becomes a question of psychology rather than physiotherapy, isn't it? I think in the psychological element of it, it's the question of, well, what motivates people. We mentioned earlier that I think for too long the reward of getting better has been kind of used as the main tool for motivating patients, and of course that's the main goal, but that can take a long time, and so maintaining engagement with something over a long time, any habits, I think they say you have to do something for 40 days before it becomes a habit, and I think whether I've got the right number of days or not, it just shows that it takes a long time to actually establish something within a routine. As clinicians, we can either encourage people on that front, or we can put them off if we give them something which simply is too excessive for them or so sterile that it's not going to either capture their attention, or it's going to be too much to fit into their daily routines. That's one side of it. But I think in terms of what we can really add is how we motivate people and how we use the technology to encourage that. Again, in the early stages, you used to get push messages from hospitals. Remember, you have an appointment. That's a very basic form of some way to engage with the patient without a human being involved. But now that can be taken on to motivational messages, sending patients encouragement, keeping that rehab thought at the front of their minds, and keeping it as an active, live or organic process. But I think some of the threats to that are, firstly, equity and accessibility. We know about the postcode lottery that exists in healthcare, but also socioeconomic factors are going to affect whether or not may affect whether you have accessibility to the technology to use an app, or to engage with some of the other technologies, like remote consultations. It may not be something which is available to everyone. So one challenge is how do we square that circle? How do we make an accessible tool? And similarly, as Andrew mentioned, the age group that you're working with, the data literacy within that, I think in my experience, some of the older age patients can be some of the most adaptable. But they need the right support, and they need the right education. And again, it's a way. How do we do something that's incredibly complex, but do it in a very simple way that's going to be easy to understand, easy for someone to stay consistently engaged with? But when we went many years ago now, when I trained as a physio, we used to talk about patients' locus of control. How do we enhance their locus of control so that they've got more influence over the elements of their rehab, and how they feel more in control of them? Because the helplessness and the vulnerability go hand in hand when you're not well, particularly I imagine on major trauma. And I think that's the challenge: is which are the tools that we use, and how do we produce these digital adjuncts which actually fulfill the needs we want, but do it in such a simple way that patients are going to feel that they are able to use it, have accessibility to use it, and are motivated to stay engaged with it.
Interesting. Maybe, Andy, the challenges of compliance in trauma rehab, and maybe adapting to complex rehab needs. What would you say?
I think it's very similar to what Nick was saying there. I mean, I don't think it's necessarily a unique to major trauma. I think, regardless of the patient that's in front of you, for the reason they're in front of you, they will all have the differing reasons why adherence may be an issue. And Nick's made some very good points there in terms of accessibility, but also the internal motivation for the patient as well. And what we've tended to find with major trauma patients is it's the abruptness of the trauma and the disruption to their life, and a lot of times their focus initially is not necessarily always on their own recovery. Some of it could be on others. It could be on the impact it has on family. It has the impact they have away from work. So there's lots of other additional sort of variables that we have uniquely to trauma. But again, I do also think that it's very much the patient that's in front of you rather than what they're in front of you for. And again, I think that's one of the key things in terms of recognizing as a clinician, it's you're adapting your approach to every patient, because that's what an individualized, clinician assessment needs to be. And again, that's one of the challenges in terms of, how can you, access a wider population of people without creating more work for yourself, essentially, because as you say, with NHS pressures, it's difficult to have the time and the resources to spend with every patient, to be able to go through absolutely everything with a fine tooth comb and come to an agreed sort of agenda with the patient, because often that's not always within our control, because the patient may be repatriated or moved on somewhere when you maybe had the work in place. But that's where I think the role of a digital app can be really great, because it can be used when they're not in front of you, and you can communicate with the patient beyond the four walls of a hospital. So I think that's another real key feature of it, really. But I think from a major trauma point of view, there are, as I said, whether it's, what we've tended to find as well is that patients, we've got to really time it right with them in terms of looking at their discussion regarding rehab and longer term prognosis, because the first couple of days, things can be really, really uncertain in terms of how their mental state is, how other people are involved with any incident they've been in. So we have to really be very sort of receptive to discussion with patients, but also the nursing staff and doctors involved, and getting feedback from all patients and all people involved. And I think that's a real sort of complexity that I have in my role in terms of coordination. It's knowing when is the right time to start engaging with rehab. Rehab starts from entry of the hospital in terms of planning it, but in terms of executing it and discussion, it can be really challenging. And I appreciate Mark at the sort of other end of that, it probably has very similar sort of challenges and problems with that. But yeah, I think it's very much an individualized thing.
Yeah, I was going to ask exactly that question to Mark. When they get home, how are you helping to help patients stay engaged with their treatment?
Yeah, I think on a basic level, it's providing the exercise program, make sure everything is demonstrated in person, but they've got easy access to that when we're not with them. Ideally, we're seeing people 2 or 3 times a week in the early stages after either an elective or trauma surgery. So it's the days in between where clients are not confident and they might have a lot of questions. So first thing is, we've demonstrated the exercise. They can go on an app, they can watch the video, they can press play, they know exactly then what they're doing, how many repetitions, how many times a day, etc. But they can also still engage with us if there's any challenges, if there's any problems. You can send secure messages in the app, obviously, to reach out if they've got any problems, and feedback is another thing. They can record, say, a particular pain score or something like that if they're doing an exercise that's been challenging or painful for them. We don't need to wait until the next session to know that actually they've been an 8 out of 10 pain while they're doing that exercise. So it really extends the benefits, obviously, of the hands-on work that we're doing in the session, and then obviously enhancing that by perhaps linking it to wearables as well. We might be tracking things like a step count, not necessarily trying to increase someone's step count, but you might be doing the opposite. You might be trying to limit them after surgery. Someone's had a knee replacement week 2 and they're doing 5,000 steps, and we might, if we know that via an app or wearable, we can go there and slow them down a bit as well. So it just gives us lots and lots of information and feedback about how the client's doing.
I think those are 2 really great points around timing and insight. The trauma point and the abruptness of it that Andrew made is really important, isn't it? Because if you have an elective surgery, you have a period of time ideally to work up towards it and prepare yourself mentally. And there's, if it's hip or knee, you might have a joint school, and there's lots of educational pieces that go around preparing you well so that your post-op recovery, you know a rough shape of things to come. But if something's come purely out of the blue and it had a very severe impact on you, then I think the ability to cope when you want to focus on the straight and narrow, anything that asks you to deviate either side of that, and I think your concentration only has a very limited bandwidth for what new things you can take on in that situation. So again, like Andrew said, it's a really great point, the timing of it, and when we introduce these things to it, and what we ask them to use it for. As Mark mentioned, if we can get insights, if we have a limited piece of time with someone as a follow-up, and you have a bit of insight into what their activity levels have been like, and perhaps what barriers they face to carrying out the exercise program, you've already got a couple of really important nuggets of information before the patient maybe is even with you. And that makes the limited time you have with them more efficient, because you've already got some sort of not necessarily directive piece of information, but something you can use to help shape your mindset about which areas you might want to explore with them.
That's interesting. It takes me on to the next sort of area of how treatment evolves. And I guess maybe throwing back to you, Nick, or maybe even others, in terms of when do we put paper in the recycle bin and move it to a thing of history? When are we ready to do that? Nick?
Well, this goes back to learning styles, doesn't it? We use, in my practice, we still give people booklets, and they can be very helpful, because although the pictures and the wording on them, which we take from classic pieces of software, are almost never quite how we would want it to be. Patients like to write things down. They like to write things in their own language. They like to do things. There's a kind of a listen, acknowledge, and reinterpret into their own understanding that they have time, certainly as an inpatient, sometimes to do that with. And so I do think being able to translate something into their own learning style is important for them. But again, just as Mark said, in terms of seeing an exercise and seeing themselves being recorded doing exercise, other people may learn by doing and then playing back to themselves. And one of the benefits of the digital bit is if you can be recorded on your own phone doing it and then see yourself doing it under verbal instruction, that's far more better way of reinforcing something than just seeing something on a piece of paper. I think there's always a role for the paper-based stuff. I know that as far as the environmental responsibilities of practice go these days, and reducing carbon footprint and reducing waste, I think there's always a role for the paper-based stuff. But again, the theme is very much going to be the right time for the right patient and in the right moment, isn't it?
Andy, would you say how has digital changed how you treat patients now, and how do you imagine that changing over time?
I think because obviously it's a very new practice still, I think it's quite difficult to say how it has already affected. But I think in terms of how it can affect, I think there's an awful lot more we can discuss. And I think the key thing, sort of following on from what Nick just said there, in terms of the individualizability in some ways, and I think particularly in my line in terms of major trauma, that's an absolute diamond, so to speak, because every major trauma patient will be different, and every management of a relatively repeatable injury will be different in terms of positions they can adopt. There's so many factors at play. If you're assessing someone's knee, but they've got let's say they've got an incomplete spinal cord injury, so I think the limitations we have with sort of given exercises on a sheet of paper, which are in some ways adaptable, because as you say, you can write the added instructions or what have you, but the ability to actually tailor and video record exercises, I think is incredible. And I've worked previously before in hand therapy, and when we've talked about physio tools as a modality and stick men, that sort of thing, what I really found so beneficial, and what patients' feedback was exactly the same, is that if a patient could be one-to-one with their therapist at the time and being given verbal instruction and then have visual feedback with regards to a video, that with a very specific exercise, because we could be talking about a very, very fine digit movement, for example, that in itself is from an adherence point of view, it's far superior to a very sort of standardized, one-dimensional approach in terms of paper or even handouts, etc. So I think that's where, in terms of digital innovation, can lead rehabilitation. It's endless in a way, because you have every single content that you made or contact you made can be different. And I think, in a way, as a physio, that makes me enthused as a clinician working with my patients, that I'm not just going into a top drawer and I'm picking out the knee exercise and I'm crossing off number 2 and number 4 and saying, carry on with these ones, because that's what happens, And I think, in terms of, with major trauma, because it's so individualized, I think we need to adapt to what the needs of the patients are. And I think this perfectly encapsulates that. And I think we, as a profession, we are open to change, but we're also quite fixed in our own ways. But I think the more visible it becomes and the more usable it becomes and the more feedback we get from patients and the better outcomes we get, should hopefully change things for the future.
Interesting. Mark, I guess when it talks about treatment at home, I mean, I have friends of mine who can set their washing and look what's in their fridge from their desk while they're at their office. And, they consider themselves to be quite high-tech people. When you go into people's homes, obviously there's quite a divide, I'd imagine, between how much adoption there is of technology. How do you find you can adapt to the individual needs and make sure that technology isn't missing out some people when they are using this?
Yeah, I think it's a lot of it is a demonstration. I think probably years ago we would have the treatment session. Obviously, you're assessing people, you're treating them, and then the tech stuff might come later. It's okay, I've sent you a link. You might be confident that people are knowing how to set it up themselves. Whereas if we see any challenges like that, we just use part of our session at the end of the session to actually go through it with people. They might have an iPad, a smartphone, obviously, and we're saying to them, right, this is going to be your program here. We're going to set it up for you. People want the best out of everything after not just the daily routine, their exercises, it's everything.
Sorry, Mark, I think we lost you're a bit choppy. I don't know if it's maybe us or guys. Can we hear Mark?
Can you hear me okay?
Oh, now it's better. Yeah. Sorry, go ahead.
Sorry. I don't know how much of that you got, but I think it's taking the stress out of people post-operatively in the first couple of weeks after surgery. They don't really want to think about anything. So it's any mild thing that could stress them out. It could be setting up an app, it could be following a link, whatever. We want to make sure we're doing that for them. So I incorporate it now as part of the session. It doesn't take long for us at all, but making sure that not only they've got access to the app, but they know exactly what they're doing. They know their way around it, video types of things. And point to add to what Nick and Andrew have been saying, like we've spoken a lot about treatment, but it's really important, I think, in just analyzing as well for motivation. If we can record, for example, could be something simple like someone's walking, someone's gait, and then we can send that to them. If we can then go back to that 3 weeks later, say at week 4 post knee replacement, and we can record again, and they can see that it might take that kind of visual representation via an app or video or something like that to realize how much they're improving. And I think that's really important as well.
I think definitely as clinicians, we always assume, we always feel that pressure to have done something to the patient. Historically, through manual therapy, something that the patient recognizes as a stereotypical physiotherapy thing. There's always feels that pressure in the session to actually, like, okay, now we do need to do something to you because that's probably what your expectations are. But I think, as Mark says, is actually it's more about what value can we add anytime we have contact with the patient. Where's the actual value? And sometimes early in the process, it's going to be mapping out the landscape, taking a long process and shortening it down into chunks and saying, this chunk, here's what we do today, to then remeasure in a few weeks' time, or here's how we map out that initial phase for you. And it may be just making them familiar with that technology. I think the adoption of a lot of these digital tools for clinicians is probably driven out of a little bit of fear of, like Andrew said, is it making our lives harder? Oh God, it's more work to do. But actually, it's not necessarily more work. It's just working smarter sometimes, isn't it?
Well, it feels like it's a collaboration, isn't it, in terms of usage, but also in designing these tools and these solutions. I wonder, maybe Nick, you might speak to how involved you feel you as an industry, or physios as an industry, are in the design of these solutions. Do you feel that you are participating in the future of digital physio, or is it being imposed on you?
I think it's a really great question. I think it's important that we are involved in it. I've obviously had the privilege of being involved in On the Mend for over 5 years now, and that's given me a chance to feel like I've been able to shape something, whether it's insight or whether it's saying, "Oh, it's not such a great idea," or just helping to offer the thoughts from my perspective, from the lens in which I see patient recovery. But I think it's definitely something that physios can't do alone. There's also crucial to have the right technology mind involved. And obviously, we've been very lucky that our chief medical officer has a background as an IT consultant as well, which is a rare thing. But I think the bit that has to go hand in hand is where the physio almost needs to say what would be ideal, but then someone else needs to say what's possible. And it goes back to that bit I said at the start. It's that because I'm full of useless analogies, it takes me back to Jeff Goldblum in Jurassic Park. Just because we could, nobody stopped to think whether we should. And I think that's really relevant to what we're trying to achieve now. There's no point us generating a huge amount of data if only a tiny bit of it is relevant to to an individual's recovery. So it's definitely a question of shaping the right tools, having adaptability within tools, but whilst you want physiotherapists involved in that, and I hope there's plenty of physios who are out there innovating, because solutions identification and solution solving is very much a bread and butter part of our skill set. I think it's necessary that physios do shape it, but it needs to be hand in hand with other professionals as well.
Mark, how about yourself? Do you feel consuming or collaborating with these products?
Collaborating for sure. I think as many people involved as possible, bringing all their expertise as well, and especially the clients getting client feedback. It could look great from a physiotherapist point of view. It could look great from a tech point of view, but if the client doesn't like it, then it's kind of back to the drawing board. So I think, always getting feedback from the service user about what can be improved, what people want, what people don't want.
And do you feel the industry technology in that perspective has missed a trick in that sense, or has it been open and collaborative in how it's designed and co-designed these solutions?
Good question. I think people are open to improving these type of products. I would say so.
That's good. And maybe Andy, yourself, do you feel you've had solutions that fit your needs and reflect that?
I think it in a way, no, because I think, I've been a physio now for over 10 years, and I think I've always been quite astounded that this hasn't already become more of a mainstream platform. It's quite archaic in a lot of the ways that we see and treat patients. Particularly, I mean, from an NHS setting point of view, I appreciate with other settings they may have more established means. But I think, for me as a physio, I always look at, how's it going to benefit me as well? Because if I can benefit from that, then surely my patients can benefit from that as well. And I think there has been, maybe just because of the ongoing onslaught and nature of working in the NHS, you just maybe don't get the time, you don't get the flexibility to work on good ideas and follow them through, because whether it's you don't know who else you can lean on to help support you with that. And that's why I think we're really, really fortunate here in Oxford that we have the Hill, which is how me and Wesley have even become in contact. Is we have a subsidiary sort of resource here within the hospital that I know a lot of places won't have. So there could be all these really interesting ideas and possible solutions going on, but sort of fall by the wayside because people just don't know how to follow them through. And within our sort of trauma network, we have a sort of monthly meeting where we're always talking about, what are people working on? What are people's ideas? And trying to sort of spread it out. If someone's thinking of the same sort of thing, that, let's collaborate and let's work together and see if we can get an agreed sort of work plan in place that we can both support each other, and I think that there's been some really success stories with that. But I think, with particularly with terms of digital physio, I think we are lacking that, and I really hope that that can improve over time. And I think when we're looking at sort of working as an individual trust, a lot of people like to sort of shout about what they're doing within the trust, but they maybe don't do it wide enough, and sort of really reach out to bigger conferences or national resources from that point of view. So yeah, I think I'm that's why I'm so keen to try and get this off the ground here in Oxford, because I can see there's a real real upscalability in this and the use of it, and essentially the overall impact for both physio and also patient.
I think it probably reflects the size of the challenge in many ways. There's probably not. Probably most clinicians would say there's many wonderful innovations out there, whether it's wearables or apps or different or robotic therapies, and lots of different types of digital solutions out there. But I think as far as the apps go, there's not one that's really been held up as a kind of said, this solves most of our problems. Mark, Andrew, and I are all physiotherapists, but I bet our working days look very, very different on across our different settings. And I think it does reflect that variability in patient, variability in setting, variability in presentation. And some innovations have sought to take a look at one element. They've said, right, we're going to do digital notes very well, and we're going to simplify that element of the equation. And that's really helpful in terms of one aspect of the broader picture. Others have looked at the exercise library, but those that have tried to do a full wraparound of booking and notes and exercise, that's a huge challenge, and I think one which still hasn't quite been fully resolved yet. But one question I wonder about is, to what extent do we feel it's helped or hindered by governance processes? Do we feel that the institutions that we all work for in the various places, do we feel that there's a right theatre for change there, or are we dealing with largely fighting against the tide of staying in the way we've always done things?
I'm happy to jump in on that if that's so. So yeah, I think within you're right. Each department or trust will have their own sort of processes and ways of working, and there'll be some. We occasionally will get patients that have come across and they come from hospital that's still got paper notes, and you can look at that and you think, that's why is it that they've not moved with the time? Is there a certain financial implication? Is there a certain governance information, data sharing, that their trust is not up with it? And I think with the NHS, a lot of people sort of think, well, why aren't you all just doing the same? We all have different imaging platforms and we all have different note systems, and there is, and I think that reflects it, that there is no, from a governance point of view, there is no one overriding sort of system that says everyone just use this because this is what we encourage everyone to use. But I think in some ways that might stifle innovation in a way, because if you're being dictated to in terms of this is what you do because this is what the trust tells you to do, you might not have that sort of flexibility to think about how we can adapt and change things. So I think it's a really interesting sort of concept as to individualized governance and how that sort of limits or encourages other people. But I think from the NHS point of view, I think there's an awful lot of that cross-sectional. There are certain trusts that are very, very forward-thinking and pragmatic with that, whereas others lag behind. And as you say, whether it's a postcode lottery point of view and a socio-economical point of view, it's a really interesting point from the wider demographic. But I think governance does play a big part in that.
And meanwhile, technology is evolving at such a rapid pace. Even in the years we've been working on the mend, artificial intelligence and machine learning has just come up and generated so much momentum so quickly. It provides a different set of considerations, doesn't it? As far as I'm aware, there's no legislation specific to AI in healthcare as yet. So we're kind of taking elements related to data protection and medical devices, taking those laws and trying to adapt them towards these things. So there's still that sense of like you this wonderful gift of technology, needing it to ensure the governance of the pathways are established and regularly reviewed as well, for it to be a safe tool for practice as well.
Mark,
Yeah,
anything to
I
add?
can just add one more thing onto that as well. That sort of our last monthly major trauma network meeting, we had a rep from a virtual reality company from the Netherlands come to sort of present to us, and they've been doing some work with St. George's on virtual reality headsets, and looking at trauma specific rehab. And everyone's sort of eyes light up and go, "Oh, this is fantastic! Great that you can interact with patients, you can set them challenges, and you can get them working on lots of different things." But the one thing that everyone asked for, how much does it cost? And that everybody that had an interest raised their hands, and he was quite clever in terms of that. He left his slide in terms of budgeting right to the end, and it's something like £14,000 for one headset, and then everyone's hand goes down. Because a lot of that, again, it comes down to the cost of it. What's the cost effectiveness, and what is this going to save our, well, what are we going to save? And I think that's one of the real shames of innovation, because a lot of it is governed by things that are out of your control, really. But yeah, I thought that was quite a poignant sort of comparison.
Yeah.
Mark, anything to share from your perspective?
Yeah, I agree with Andrew. I think, over the year setting up this company, we've been presented with lots of various different things in terms of technology. But firstly, cost is going to be one of the most important things. And then again, is it valuable to the client? If I enjoy using the technology, say, for example, just to assess someone's brain movement in their knee, and it's simple for me, is it that different from using like goniometer that still takes like 2 seconds to do? The actual outcome is the same. So it's kind of, again, the cost of something like this, is it going to save us time, and is it going to be worth it in the long run? So I'm interested to see, like, if you could skip forward 10 years, what kind of AI is going to do. Is it an assessment as well? It could be very interesting to be.
Well, that's too tempting to miss that question. I'm going to throw it right back at you, actually, in 10 years' time. So let's think about some questions to put in that, hands-on treatment, paper, phone calls, these types of things. What do we see us not having in 10 years' time? And what might we envisage us having in 10 years from now when it comes to treating people in a physiotherapy context? Who should I ask first on that one? Nick, you seem to be raring to go and answer that.
I don't know about that. It's a good question. My dad always used to say the future's wisely hidden, and I'm not going to offer that as just the full answer, but I think to some degree it is. So many things when we look 10 years previous to now, to imagine that we'd be working with this level of technology and these level of options. People now want data in their daily lives when they're keeping fit in the gym. I put a wearable on in the gym, and I'm interested in the data, not because I'm a particularly good athlete of any sort, but because actually it motivates me to go. Just the reward of how many days can you do in a row? Can you hit this target every month? And if you do, you get these diamond and Hall of Fame, and you end up working up your way up the ladder. And it motivates me to go. If I'm behind and I'm not going to hit it, I will find more time. So there's some ways in which case, well, data is a part of our daily life. People want to know more about their own basic profile. I talk to patients every day about everyone has a match fitness. We're all match fit for something. We just all have different versions of what a match is. And I think the trauma one is a real conundrum with this, because of that it's a never planned thing. But in the elective side of things, I think people are okay now with being asked to gather data, with being asked to have data as part of their recovery. In many ways, they wanted. I think thanks to the fitness industry and the way that commercial rewards are now a fundamental part of daily life and keeping fit, and partnerships and associations. I think commercial reward for rehabilitation. I see that as being a genuine area of growth. And I think in terms of the healthcare industry generally in this country, it is at a point where elective stuff and and many of that sort of thing is going to become more part of the private sector, I think, than perhaps less part of the NHS with those huge waiting lists. But I think that may shift. I won't use it sort of compare it too much to an American model, but I think remuneration packages and benefits packages that are offered by employers are going to increasingly find that healthcare provisions are part of that, and that will become something that's more and more valuable to us as I think in the next 10 years. So certainly collaboration between the private sector and the NHS, when they work together, they do things ever so well. And I've seen many examples of that in and around London. So collaboration between private and public offerings in this country, and certainly not somehow having a bit of evolution to the point where commercial rewards and adopting many of the things that keep people motivated in the fitness industry. There's definitely a learning curve for us to go through within healthcare. But I'd like to believe that it's not going to be met with layers of red tape and bureaucracy and historical attitudes between, towards different service sectors in this country. So that's what I'd like to see anyway.
Andy, a step change in trauma, what does that look like to you?
Well, I think the major distinction between sort of, as Nick was sort of saying there, in terms of elective and trauma, is we're looking at reactive or proactive. Elective surgery and elective care is very much so you can preempt things and you can be proactive with things, whereas trauma is very reactive. So I think you've got to essentially, you're always slightly behind the curve with things, but that's not to say that can't be improved. So I think in terms of where we see ourselves, one of our particularly trust values here in Oxford is about, going digital. So we might be in a very sort of in a good position in terms of looking at digital innovation and getting that through trust approval and things like that. But I know that's not going to be with everyone. But I think general with regards to trauma, I think it's very much dealing with a situation when it arises you. But I think that comes from the physios themselves, because we can still be proactive in our approach, even if the patient's care is reactive. So I think a lot of that comes through teaching as well. When we think about students coming through university and teaching with there, I think it's I think that's a real possibility of how we can, as a population of therapists, be more proactive with our practice, and that comes through day one when you go to university, and I think that could be a real sort of change in the way that digital innovations is accepted within physios, because we all change our practice probably over time and adapt it to certain things. But if an implementation can be sort of from a much earlier stage in your practice, it becomes more long stayed then. So I think that's another real sort of area in terms of where the next sort of 5 years can go, is in terms of, can we incorporate these things? I know they do a lot of virtual reality in terms of like anatomy training, and they do a lot of it in sort of medicine as well, and I think this will slowly come through, and that will then implement into actual daily practice as well. And I think that's another real key element that we want to be promoting as therapists, in terms of everyone will have their own agenda, but in terms of if we can be positively influencing the younger generation to be thinking of things that way, because everyone in the next 10 years, I don't know the statistic, but in terms of how many people will have access to smartwatches and smartphones and iPads, will be probably closer to 100% than it is now. But so I think that's a real sort of interesting point, is if we can influence the training process to adapt and to take on digital innovations, I think that could be another real step forward in terms of the overall uptake of digital innovation.
Interesting. Well, Mark, you're welcome to add to that from the home perspective. I guess we all imagine in 10 years we'll have robots answering our doors and doing our washing and putting our kids to bed. But where does the physio fit into that scenario?
The best thing I've heard is, obviously we have smart watches and smartphones. I've heard, I don't know whether it's true or not, about smart joint replacements, that it's already tracking. So we can just look at the phone and we know via the actual joint replacement itself, via some sort of microchip or whatever it is, the patient is flexing their knee to 100 degrees. They've done X amount of steps per day. Whether that could be an actual thing or not, I don't know. But no, I agree with Andrew. It has to come in at university level. I think there'll just be more of a blend of physiotherapy and technology, but it has to come out. I studied 2006, 2009, and I think how it would look now in terms of going to university to study a physiotherapy degree I imagine, would be completely different to back then.
Excellent. Well, I have a feeling we could talk for a lot longer than 1 hour, but that has neatly brought us to a close. Thank you, everyone, for your time and thoughts and contributions. That was a really interesting discussion, and I will be sharing this with the audience that couldn't maybe make this one, and we'll have future sessions in our World Series, so you're welcome to listen in to those and share thoughts as we go through. But again, thanks to all for sharing today's thoughts on the future of digital physiotherapy. If anyone in the audience wants to find out more about On the Mend, or maybe wants to reach out to any of the speakers, just send us a note at info@onthemend.com, and we'll pass on that message. But again, thank you all, and wish you a good day ahead. Thanks all. Bye-bye.